GYNs. I work at Barton Women's Health, as well as I see patients at the Community Health Center at the OB and GYN clinic there as well. I have no financial disclosures. So one of the main questions I get a lot of times from people is just what is menopause? Essentially, menopause is that last period that you have that's then later confirmed by having 12 subsequent months with no further periods. In the United States, the average age of menopause is about 51, and the majority of women will go through menopause somewhere between 45 and 55. What is not menopause? Menopause is not a disease. It's actually a normal, natural event. It's something that we will all, as women, eventually go through. It's marked by a reduced functioning of the ovaries due to aging, and this leads to lower estrogen levels in our bodies. It also marks the end of fertility. Luckily for us, we're not like chickens, and I don't always have to see the number of eggs that are there or not. Perimenopause is this other term that kind of refers to this gradual transition time. So in our lives, we kind of can define our lifespan as far as relating to our ovarian function into premenopause, which is the time between your first period, so menarche, and menopause, so anything before that. Menopause, which is that cessation of periods, so stopping your periods. And then postmenopause. Perimenopause is this kind of gradual transition between your reproductive years and menopause. And for many women, this is a longer and a more unpleasant transition than you may like. It can last for up to 4 to 10 years. What do you expect to see when you're going through perimenopause? Many women may have shorter menstrual intervals, meaning that the time from the first day of one period to the time of the next period is actually shorter. People who had maybe 28-day clockwork periods for years and years may start to have periods every 24 days or every 21 days. You might start to skip a month. You have a period and then you go 2 to 3 months without one. Your periods may get lighter, although some women do experience shorter but heavier periods during this time. Another really common symptom is hot flashes or night sweats. And night sweats are essentially just hot flashes that occur during the nighttime. These can precede the time of menopause in those perimenopausal years as well. Some of these symptoms can become so bothersome that they might interfere with your quality of life, and for that reason, some women do seek medical intervention for some of these symptoms. So we've talked about menopause and perimenopause. I'd like to talk a little bit about induced menopause, and this really refers to women who have whose periods stop due to sort of artificial reasons, and that can be due to either surgical removal of the ovaries. It may be to chemotherapy that they've received for another type of cancer during their life. Radiation therapy, particularly radiation therapy to the pelvis, can be very damaging to the ovaries and can put you into menopause prematurely. And then there are other medical conditions where you might be on a medicine that actually also stops your periods and gives you an induced form of menopause. Women who have induced menopause or early menopause also tend to have more severe symptoms, or the same symptoms that you get with regular menopause, but just a little bit more intense. Uh-oh, I don't know about that. Another question that I get a lot in my office is, what about a hysterectomy? I mean, if you have a hysterectomy where your uterus has been removed, you're obviously not having periods, but does that mean that I've gone through menopause at that point? And really, the key to this with a hysterectomy is what happened to the ovaries. So even though menopause is marked by this cessation of your periods, it's really the ovarian function that's driving the process. So if you've had a hysterectomy where you've removed just the uterus and maybe the fallopian tubes, but the ovaries are actually still remaining, that is not menopause, and your body will continue to go through those normal hormonal cycles and go through kind of natural menopause at the same time. If you have a hysterectomy where you remove the uterus, the fallopian tubes, and both of the ovaries, that would be functionally surgical menopause at that time. For some women, they may go through this menopausal change a little bit earlier than others. Early or premature menopause refers to these symptoms that are either natural or induced that happen at age 40 or earlier. This occurs naturally in about 1% of women, and this can be due to genetic factors like Fragile X syndrome, some metabolic changes, and some autoimmune diseases. As I mentioned earlier, if you do go through premature menopause, oftentimes your symptoms are a little bit more intense than they would be for women who are going through it a little bit later, just because of the relative difference in age. Additionally, it's important to note that if you have symptoms of early menopause, if you stopped having periods for any reason, if you're having hot flashes, these are things that should be thoroughly evaluated by a physician because it also can signify underlying medical conditions that would be important to recognize and treat. With premature menopause, you also have more years without the benefits of estrogen. So that puts you at risk for getting some of those estrogen-related diseases like osteoporosis as well as heart disease. And so that kind of plays into our conversation if we've confirmed that as far as the role and benefit of potentially being on hormone replacement therapy to give your body that benefit up until the time when you would have more naturally gone through it at a later age. So we've talked a lot about kind of different types of menopause, and I've mentioned the symptoms, but what are those symptoms that we think of? I think the first one that most everyone thinks of is the hot flashes and the night sweats. In all honesty, we don't really truly understand why night sweats happen or what causes the hot flashes. We think that it might have to do with some increased sensitivity in a part of our brain that's basically like our body's thermostat, and that the hormonal fluctuations make that thermostat just a lot more sensitive, so you kind of go from being hot to cold very quickly. Other common symptoms include vaginal dryness, difficulty sleeping. Many women experience mood disturbances of feeling more irritable, having less patience, feeling depressed. There can be changes in our skin and hair. Decreased libido and weight gain are also very common, as well as a feeling of kind of this brain fog or memory problems that comes around that time as well. Not all of these are hormone related, and some of them, like your hot flashes and the memory problems, tend to get a little bit better after menopause is completed. They also could be referred to as the 7 dwarfs of menopause. So we'll start by talking about hot flashes. Very, very common. About 70 to 80% of women will experience hot flashes. And like I said, often starting in that perimenopausal transition. Interestingly, only 20 to 30% of women actually seek medical advice for these. So lots of people are out there having them, and a smaller percentage of people are actually bothered enough or seek care for that. I think it's also important to notice that they last for a long time. They can last for up to 7 to 8 years, with 4 to 5 years of that potentially being after you've completed that final period, so after menopause. A lot to look forward to. I like this one. Lots of helpful suggestions. Vaginal dryness is also very common. Vaginal dryness is often something that we see a little bit later, more in that postmenopausal period. Because of the decrease in estrogen, the lining of the vagina actually becomes more thin, it becomes drier, it loses some of its natural elasticity or stretchiness, and then you also have decreased secretions and lubrication. Because of all of these changes to that lining, you also change your natural kind of acidic pH balance, so the acid-base balance of our body and the vagina is supposed to be very acidic, and because of the change in the mucosa, it actually can become a little bit more basic, which puts you at higher risk of getting other infections like bacterial vaginosis or yeast infections, which can be bothersome. There's a kind of group of symptoms that we refer to for these changes that are associated with the decrease in estrogen on the vagina called the genitourinary symptoms of menopause. It's basically kind of vaginal and urinary symptoms kind of all together. And this may be irritation, feeling like you have to go to the bathroom more frequently, feeling of some pressure or urgency, like you have to go right away when you have to go, and sometimes a little bit of pain or leaking. These symptoms are very well treated with local vaginal estrogens, which can be given in the form of either a cream, a tablet, or a ring. And the local estrogen does not have the same side effects or risk factors that we'll talk about when we talk about systemic hormone replacement therapy. You may have heard about some of these other kind of more alternative treatments for vaginal dryness, like the Mona Lisa. Some places call it vaginal rejuvenation, which just sounds so lovely. But it's really kind of experimental at this point still. There were some very promising studies that this might be a way to treat that area and give a long-lasting effect. But some more recent studies have shown concern for scarring and damage to the area and sometimes increased pain. So as at this point, I don't recommend that to my patients. I'd like to see a little bit more data on the safety and efficacy of that before we start using it more broadly. There are also over-the-counter things that you can purchase that can help with some of these symptoms. There's vaginal moisturizers like Replens, as well as things you might find in your pantry, like coconut oil. I feel like you can put coconut oil basically anywhere and it will help. As well as olive oil. Vaginal lubricants are important. And then also this idea of vaginal exercise. So having sexual activity, stretching, and pelvic physical therapy can help increase that elasticity as well as increase the secretions by kind of using those muscles. Two other medications that I won't touch on quite as much are Osphena as well as Intrarosa. These are other prescription medications that also target this. So we might feel young at heart, but our bodies do start to notice these changes. Sleep problems are super common in menopause, and they're very multifactorial, meaning there's a lot of reasons why you might start to have difficulty sleeping as you get into this perimenopausal and menopausal transition. There are hormonal changes for sure that change the quality of our sleep. Women who are in menopause tend to spend less time in the REM or the restful sleep state. So even if we're getting sleep, it's not as restorative to us. And then there's kind of this vicious cycle that can happen with sleep as well. You start to have difficulty sleeping. If you're having hot flashes, that may be the trigger. And then that leads to feeling more tired, which then when you're more tired during the day, you start to feel like you're having difficulty concentrating, having a hard time with your memory, makes you feel kind of irritable when you're at work and you're feeling those things, then you don't work as efficiently. And that leads to more stress because you're stressed about what's happening with all of the things at work and life. That can lead to decreased coping and feeling more irritable. So even when you get home, you then feel like you have less patience. And then we kind of beat ourselves up about all of these things, and then we're not sleeping well again. So definitely kind of a multifactorial cycle that can happen. And so we try to address it, kind of looking at each one of those issues. There are some lifestyle changes, things that we can do just by changing our habits that might help with some of those things. There's this concept of sleep hygiene. Basically, where do we sleep? How do we sleep? So think quiet, dark, and cool is the best environment to really have restful sleep. Having a white noise machine or a fan by your bedside also can help to kind of keep you in that more restful sleep state. Different relaxation techniques like guided imagery, yoga, and meditation can also be very helpful for sleep problems. And avoiding our screen time. And we all have our phones and Kindles and televisions. Get the TV out of your bedroom. Make sure you spend at least an hour before bedtime where you're not looking at a screen, because that definitely stimulates our brains in a way that makes it more difficult to fall asleep and to stay asleep. Also avoiding stimulants, so things like caffeine, other medications. If you're on prescription medications, it's worthwhile to talk to your doctor and see if some of them might be better taken in the morning time versus the nighttime. Some of those medications for other diseases may have side effects of sleepiness, which you might want to then take at nighttime, so that adds to your benefit. Also, avoiding eating large meals in the afternoon can also help. I don't know how many of you out there have husbands who snore, but our partner's sleep habits also can make a big difference. Maybe they're snoring just all throughout the night that's waking you up. Maybe they're watching TV till late at night and coming in once you've already gone to sleep. So kind of addressing some of those sleep habits too can be helpful. And then exercising daily also has been shown to help improve sleep. Besides our habits, which are easy to talk about but hard to change, There are some medical treatments that you can use. There's over-the-counter medications like melatonin, valerian root, and chamomile. Lavender and passion flower have also been shown to be helpful. Over-the-counter medications like Benadryl or Unisom, which is basically a cousin of Benadryl, can be helpful. Seeing a therapist and doing cognitive behavioral therapy can help with sleep issues too. And then there are prescription medications, which I generally recommend using with caution because they can be a little habit forming and can be difficult to come off of. And of course, if you're having hot flashes and night sweats that are waking you up at night, treating those hot flashes may be very helpful too. Weight gain is definitely something people talk a lot to me about as they kind of come into their 40s and early 50s. Some of the weight gain that happens in midlife is not related to menopause per se, but just aging. As we age, there's a change in our body composition. We tend to have less lean mass. We deposit our fat in different locations, and that can then lead to a slowing of our metabolism, so it makes it a little bit harder. I think nobody likes to hear it, but unfortunately, there's definitely this finding that as we age, we have to exercise more and consume fewer calories to be able to maintain our weight. And so just kind of being aware of that as we age, that's a normal metabolic change. Hair loss, also very common. A lot of women experience the sensation of thinning hair. This can kind of be in two general patterns that we see associated with menopause. There's diffuse shedding, so just kind of general thinning and feeling like every time you comb your hair or would take a shower, there are just gobs of hair on your hands, kind of like the hair loss you might experience after having a baby. That does luckily tend to resolve on its own, and it usually gets better after about 6 months. And then there's female pattern hair loss. Similar to kind of male pattern baldness, this generally presents with kind of a widening of the center part and then loss of hair mainly at the crown or top of your head. It's not very well understood, but we think it might be related to the changes in the relative levels of estrogen and androgens, or the male type hormones that we have in our bodies, and kind of leading to this hair loss. Having good nutrition and thyroid disease also can cause your hair loss. So if you are experiencing hair loss, one of the first things we might check is your thyroid to make sure that that is normal, because thyroid disease is also more common in women as we age. Some studies have shown that having a healthy diet, low in red meat, low calories, and having a lot of zinc, iron, vitamin T, and biotin might help decrease some of the hair loss. And then there are medications like minoxidil and anti-dandruff shampoos that also can be helpful. Seeing a dermatologist for these things can also, they may also have some additional treatments. There's lots of things that target out there for our skin and hair as we go through menopause. Low libido, also very, very common. And again, kind of multifactorial. A lot of the other symptoms that were talked about with menopause, like sleep issues, mood issues, can also then lead to feeling a lower sexual desire and sexual drive. Same thing with vaginal dryness. If you're having pain with intercourse, if you're having that decreased lubrication, it definitely makes it more challenging. And then the sleep disturbances. Additionally, menopause comes at this time in our lives where a lot of people are experiencing major life transitions. There may be children leaving the home. You may be going through retirement. You may have changes in your relationship with your partner. And all of these factors can lead to just stresses on libido. A lot of times I'll get asked, like, what's the deal with testosterone? So I think when we think about male and female hormones, estrogen is primarily thought, and progesterone are thought of as female hormones, and testosterone is the male hormone. The truth is, even men and women, we all have both in our bodies, and it's all kind of about this balance. Very low levels of testosterone may be related to low libido and weaker orgasm in some women, and for this reason, there are lots of studies going on right now looking at this issue to see if using testosterone might be helpful for low libido. Currently in the United States, there's no FDA-approved formulations of testosterone in Canada or the United States. There are some in Europe. Women in the United States will sometimes get prescriptions for off-label use of testosterones that are designed for men at a much lower dose. There's this patch that has been seen in Europe that's very promising for this, but Canada and the United States drug approval regulation bodies, the FDA, they're waiting for a little bit more safety data before long-term before approving that here. If you are taking testosterone, some of the common side effects that you might experience could be acne. You can have facial and body hair growth. Very rarely, there might be enlargement of the clitoris and then irreversible voice deepening. So I think it's really important to be aware of those side effects before taking that medication. And then because we have enzymes in our bodies that convert testosterone in our peripheral fat to estrogen, taking testosterone, you also have the same risks as when you're taking systemic estrogen therapy because it gets converted to estrogen by our bodies. So you have kind of these increased risk of blood clot as well. So any hipster over here will tell you that a beard is fashionable and super in right now, but it might not be the look that you're going for as you go through this. DHEA, just to talk briefly, is a hormone that is converted to testosterone and estrogen by our bodies, and they've looked at intravaginal use of this to help treat low libido and dryness. And so far, there's been some very promising studies seeing that it improved kind of all benefits of dryness, desire, arousal, and orgasm without significantly elevating the blood levels of estrogen, DHEA, or testosterone above their normal postmenopausal levels. So definitely an area to kind of keep watching, but still a very new drug. I'm just going to take a sip here. So now that we've talked about all of these different symptoms, I'd like to move into talking a little bit more about how we can treat and manage some of the symptoms if they're very bothersome. So particularly kind of this slide's talking more about hot flashes. So lifestyle modifications can be helpful, again, changing our habits, dressing in layers. So if you get super flushed, you can take off your scarf, you can take off a layer or a sweater can be helpful. Avoiding caffeine, alcohol, spicy foods, all of the fun stuff as usual, has also been shown to help. Doing yoga, meditation, and guided imagery can be helpful to kind of cope through those hot flashes. There are some non-hormonal options like antidepressants, anti-epileptics, and a blood pressure medication that we'll touch on, and then hormone replacement therapy, which is estrogen and progesterone. So what is hormone replacement therapy, and who do we use this for? We generally will use hormone replacement therapy for women who have moderate to severe hot flashes that are interfering with their daily life and who do not have any reasons to avoid using hormones, and we'll go over those a little bit. By far, hormone replacement therapy is the most common treatment for hot flashes. It's one of the most effective, and the goal is to improve and relieve those menopausal symptoms. Most women who present for hormone replacement therapy present sometime in their 40s to 50s. The risks of, so why not put everybody on hormone replacement therapy? You know, if we're losing our estrogen and it's naturally going away and it's causing all these bothersome symptoms, why wouldn't we just start everybody on it? There are some risks, although the risks are relatively low in young, healthy, perimenopausal and postmenopausal women. Additional symptoms that might help, might also respond to hormone replacement therapy include some of the mood symptoms, the vaginal atrophy, sleep disturbances, and then some of the just joint aches and pains that people feel like. I'll often say that those get a little bit better when you're on hormones. I do want to point out again that if your symptoms are only dryness, rather than using systemic hormone replacement therapy, it's really better to use local estrogen for that because it doesn't have the same risk factors. So when we start hormone replacement therapy, we are starting this to treat the symptoms. We're starting this to treat hot flashes. We're not using it to help prevent disease. There are a variety of different types of FDA-approved estrogen and progesterone treatments, and these come in the forms of pills, there's patches, creams, a ring, gels, and the doses of these vary based on their preparation. Who is a good candidate for this? In general, we want to start hormone therapy for women who are healthy, having symptoms, and who are within 10 years of menopause or under 60, and who do not have any of the contraindications. For women who have been on hormone replacement therapy and are experiencing recurrent hot flashes after stopping it, we generally try to think about considering some of those non-hormonal treatments because they tend to be beyond that 10-year mark. Contraindications or reasons to not, people who should not have estrogen therapy include women who have past or active breast cancer, women who have coronary heart disease, a previous blood clot like a deep vein thrombosis or a pulmonary embolism, a stroke, active liver disease, unexplained vaginal bleeding, if you have a uterine cancer, or if you have very high triglycerides. So the different types of hormone replacement therapy that we can use, generally, the estrogen is what gives most of the benefit as far as treating the hot flashes. But if you have a uterus, if you have not had a hysterectomy, you need to have progesterone in addition to be able to help protect that lining of the uterus. In addition to relieving the hot flashes, the estrogen also can stimulate the lining of the uterus. And so progesterone helps protect and counteract that effect so that you don't have a uterine cancer caused by what we call unopposed estrogen. Additionally, the first studies that were done looking at hormone replacement therapy were primarily with pills, and we found later on that using a patch or transdermal forms of estrogen actually has a lower risk of blood clot than the oral pills do. That being said, the absolute risk of blood clot and stroke is overall very low, and so if women prefer an oral tablet and are otherwise healthy, that also is very reasonable. The progesterone form can be given in a couple of ways as well. There's two main types of progesterone. There's Provera, and then there's Perimetrium, which is a micronized, a form of progesterone that's very similar to the one that your body makes. There also could be the progestin IUD. We can use Mirena to help locally protect the lining of the uterus. The Perimetrium and Provera can be given either continuously, where you take it every day of the month, or cyclically, where you take it 14 days out of the month. Some women choose to do it cyclically because they're bothered by the side effects of progesterone, which can include some feeling of bloating, also some sleepiness. But for many women, it's easier just to take it every day. If you do cyclical progesterone, you may have some cyclical spotting, even if you're postmenopausal, especially in those first few months as you start that. For premenopausal women, so women who have not yet had that final period, if they're having bothersome symptoms, we also can use very low dose birth control pills to help with that, and then transition them to hormone replacement therapy around age 54 at the time of average menopause. For women who have had a hysterectomy, and do no longer have that lining of the uterus there, they do not need the progesterone. And so we typically will choose to treat those women with estrogen only. So once you're on it, if you've chosen to do that, how long do we continue this for? The party line and kind of goal is to use the lowest dose for the shortest period of time. In general, the recommendations are to not use it for more than 5 years if you're using combined estrogen and progesterone treatment, or more than 7 years if you're just using estrogen alone. But that being said, it's really important to know that the treatment can be individualized. It's not we don't discontinue it simply just based on your age alone. If you have talked with your doctor and have come to agreement that the benefits of continued treatment outweigh the potential risks in your given situation, continuing use is very reasonable, as long as we kind of continue to readdress, okay, we're going to try this for another year, at what point are we going to try coming off of it? Because of this, I think that plays into a lot of the fact that up to 40% of women who are between 60 and 65 still have persistent hot flashes that impair their quality of life. So it's definitely reasonable for some women to continue it a little bit longer. So I've kind of talked and alluded to the risks of hormone replacement therapy, and I think that this is a really good example of, again, one of these pendulums of medicine that has swung back and forth over the course of time. For a long time, people were very kind of supportive and used hormone replacement therapy a lot more liberally. And then there was this period of time where we were very restrictive of it. And a lot of that had to do with this large study called the Women's Health Initiative. It was a large randomized control trial, which means it was a placebo-controlled trial. They gave women there were 3 different arms: a placebo group, an estrogen group, and an estrogen plus progestin group. And the main goal of the study wasn't actually to treat hot flashes. It was actually to look to see if by giving women hormone therapy, if it reduced the risk of having coronary artery disease. The women who enrolled in the study were anywhere between age 50 to 77. The average age was actually in their 60s, which I'd like to point out because it's a lot older in that study group than who we now recommend hormone replacement therapy for. This study went on between 1990s to 2002, and it was actually stopped early when they noticed that there was a statistically significant increased risk of breast cancer for women who were in the estrogen and progesterone only arm. The answer that they got from the study for their primary question of heart disease was no, it doesn't help to prevent heart disease to be on hormones, but it also doesn't increase it. When they looked at these kind of more refined analyses of the different complications that we were seeing, other diseases that they were kind of seeing the effect on, the breast cancer was the big ticket item that got everybody's attention. There was this increased risk of women having breast cancer who had combined hormone therapy. But I'd like to point out that while because this was an enormous study, there were so many women in this study and they followed them very thoroughly for a long time, that even though this was a significant increased risk, the actual risk of that was 9 additional breast cancers per 10,000 women over the course after 5 years of use. So for many women, the clinical significance of that risk, some women feel that's acceptable to them. There are other people who feel like any increased risk of breast cancer is not acceptable to them. So I just like to point that number out to my patients because the media presentation of this study at the time made it seem like everyone who uses hormone replacement therapy had this really high chance of getting breast cancer. And it's true, it did increase the risk, but overall it was this 9 per 10,000 over 5 years. I also think it's really interesting that in their study, the estrogen-only arm actually had a reduced risk of breast cancer. There were 7 fewer cancers in women who used estrogen only compared to the placebo group. Some of the other complications that were seen in women using hormone replacement therapy included blood clot, and this affected both the estrogen only and the estrogen progesterone arm. This was an additional 18 per 10,000 women, additional 18 blood clots. However, when they sub-analysis of the transdermal estrogen, that increased risk was not seen, and so that's why we do often recommend the patches over the pills. The medications that they were using also in the Women's Health Initiative were Provera and Prempro. So it was the conjugated equine estrogens and Provera. And those are available, but not often our first lines these days. There was also an increased risk of stroke in both groups, about 10 additional kind of for both groups, so 9 versus 11. There were some benefits seen, I think, that are also important to point out. Overall, the women who used hormones had an overall improved quality of life, and they were less likely to die overall by anything. So there was a 30% decrease in mortality in women under 60. We also saw a decrease in the estrogen-related diseases like osteoporosis, less type 2 diabetes, as well as a lowered risk of colon cancer and a reduced risk of cataracts. Besides kind of the risks and benefits, there's also some side effects, as with anything. The side effects of hormone replacement therapy most commonly are breast tenderness. Some women do experience even an increase in kind of the density of their breasts that you may even be able to pick up on a mammogram. There can be vaginal bleeding, like we talked about, especially if you're using cyclical progesterone. This feeling of bloating, and then mood symptoms. Mood symptoms are hard. They're part of the problem. They may also be part of the solution. I'd like to shift gears a little bit now and talk about some of the non-hormonal options. So for women who have moderate to severe hot flashes, but are not good candidates for hormone replacement therapy or who choose not to use it, someone who has a breast cancer per se or other reasons, or women who have stopped hormone replacement therapy but still have persistent hot flashes, we start to think about some of these non-hormonal options like the antidepressants, anti-epileptics, clonidine, and then we'll talk about some alternative therapies, some that are very promising, some that are more inconsistent, and some that unfortunately have been shown to be fairly ineffective. So antidepressants, when we traditionally think of antidepressants, we expect to see this kind of long build-up time of when you start taking them to when your symptoms improve. And the good news with using antidepressants for hot flashes is that you tend to respond a little bit more quickly than what we tend to see for clinical depression, more in the matter of days rather than weeks. They were shown to be equally effective in women with breast cancer who have undergone through surgical as well as natural menopause, so they're a good use for all women. The only FDA-approved formulation of an antidepressant for the use for hot flashes is Brisdel, which is essentially a super low dose of Paxil or paroxetine. And I'd like to point out that women who had breast cancer who are on tamoxifen, this medication should be avoided because of some interactions there. Other SSRIs and other antidepressants that have been shown to be effective for hot flashes include Wellbutrin, Celexa, Lexapro, and Effexor. And a lot of times I'll also use these medicines if someone's having kind of a combination of symptoms. It helps treat depression as well as the hot flashes too. Or if someone's already on an antidepressant, increasing their dose or adjusting that may also help improve those symptoms. Some of these, particularly Wellbutrin, may also help improve libido. We can be a little moody. Hopefully our families will watch out for us. Anti-epileptics, the main one that we think of is gabapentin. It has been shown to be very effective for women, especially who are having night sweats or hot flashes at night. At high doses, it can actually be as effective as estrogens, but the side effects really limit its use in that high dose. The side effects of dizziness, headache, this kind of brain fog and disorientation make it really difficult to tolerate higher doses. So one kind of downside for this one. They've also looked at combining it with SSRIs, and that wasn't found to be any more effective than using it on its own. So some of the alternative therapies that have been found to be more promising if you want to avoid something avoid medications. Cognitive behavioral therapy has been shown to be very effective for menopause-associated insomnia or sleep disturbances, as well as hypnosis, which can work for both sleep and hot flashes. And then the mind-body-based therapies, so guided imagery, meditation, yoga, and deep breathing have been shown to be helpful. Some of the things that are a little bit more inconsistent include a lot of our plant-based therapies, things that you might find in the natural food stores and things like that. Isoflavone and some of the herbal therapies have shown in some of the literature to have no benefit over placebo, but some have shown that they may have some benefit. These are typically what we think of as phytoestrogens or estrogen type things that are found in foods like soybeans, lentils, chickpeas, flaxseed, fruits, and vegetables. There is some concern that these phytoestrogens may contain some estrogenic, meaning stimulation of estrogen receptors, and anti-estrogenic, doing the opposite properties. And for women who have breast cancer, most experts feel that it's okay to consume some dietary soy, but that we should avoid supplementation with soy products until they've had a little bit more safety data has been shown. Some of the more inconsistent ones too, black cohosh and some of the Chinese medications like Donquai have been inconsistent in the data, as well as paced respirations, weight loss, and exercise. Acupuncture is something that a lot of people ask me about, and unfortunately there was this big meta-analysis of 6 randomized control trials for acupuncture, and it was found to have no benefit over placebo. However, I think it's important to point out that there were several studies that looked at the combination of acupuncture and some of the Chinese herbal remedies like Donquai that actually did show some benefit, so there may be some potential there. Evening primrose oil and flaxseed alone, those didn't work out so well. We can always look for our own ways of coping with our hot flashes as well. at this point, I kind of want to just talk a little bit about this idea of bioidentical hormones. Just by a show of hands, who here has heard about bioidentical hormones? Okay, so bioidentical hormones, technically, it refers to hormones that have the same structure as what's produced by the body. And I think it's really important to point out that there are many FDA-approved formulations of estrogen and progesterone that are derived from soy and plant-based extracts that are modified to be identical to our body's own hormones. There's only a few of them that are still this conjugated equine estrogen, which is essentially estrogens that are derived from pregnant horses' urine, and I can understand why people may be a little averse to using that. Those ones are Premature and Prempro. Those are the pills. However, in popular culture, bioidentical hormones has this totally other kind of connotation. It's used to refer to this custom compounded regimens that can be as gels, creams, suppositories, or pellets. And a lot of times these preparations are used and dosed based on serial blood testing or saliva testing. One of the difficulties with that is that there's really no good reference range for what your estrogen level or progesterone or testosterone for that matter should be. So there's no data to guide how these medications, if they're looking at blood levels, like how do you even interpret that? The goal of hormone replacement therapy is usually guided by dosing to improve symptoms rather than a blood level, which is a little different than when we think of other hormones like your thyroid. If you have hypothyroidism, we check your TSH and we adjust the dose of the medication based on that. Unfortunately, we just don't know those reference ranges for hormones. Our hormones, because they're produced by pulsing from our brain, they can be quite fluctuant during the day, depending on the time of day, the times that you've eaten. And some of the salivary testing that a lot of people will do has also been shown to, number one, not correlate well with blood levels, and also have a lot of inconsistency throughout the day and based on what you've eaten. Overall, generally, for most societies, the American College of OBGYN and the North American Menopause Society and the FDA don't recommend bioidentical hormones because there can be some problems with them. The contents of these compounded medicines, the dose, the quality, the sterility of these products, it's not subject to any regulation. The FDA does not have any oversight of the production of these in compounding pharmacies. Additionally, there's no good trials or studies that have shown that these are safe or that they work. When they have been tested, a lot of times the potencies of these compounded formulations, as well as the absorption, can vary quite a lot. And that not only leads to fluctuation of your symptoms, your cream might be right on track one month, and then the next time it's a little bit of a different preparation, and so you have more symptoms. But also it puts you at risk of having an imbalance of the estrogen and progesterone, particularly if you have a uterus. We see it everywhere. If you go on, I feel like, any magazine or TV show, you're gonna hear and see celebrities who are out there promoting these things. Suzanne Summers is a big proponent, Cindy Crawford, even Oprah. Love Oprah, but not for this. Talking a little bit more about the fluctuation of the quality and the dose. There was a magazine, More magazine, that did an investigational study looking at bioidentical hormones. They essentially sent a prescription for Triest, which is one of the most commonly compounded creams that's used. It's a combination of 3 different forms of estrogen. And they sent it to 12 different compounding pharmacies. And then they tested what they got back. And what they found was that of the 3 different types of estrogen, the majority of them ranged from anywhere between 20% to 260%, over 2.5 times the dose that was supposed to be contained in that medication. And also to note that the progesterone amount in those medications was often subtherapeutic. So they found that they had basically too much estrogen and not enough progesterone. I unfortunately, in my own practice, have actually seen a handful of women who I have diagnosed uterine cancers, who were using bioidentical hormones that were probably stimulated because of insufficient protection of the lining of the uterus from progesterones. There have been several doctors that have had disciplinary actions from the medical board. Prudence Hall is actually Suzanne Summers' key person who she likes to. She was put under disciplinary action last year, is no longer able to practice as an OBGYN because of negligence, because of failing to diagnose a uterine cancer. And the Rancho Mirage was a big hit in the early 2000s, and he also was forced to surrender his medical license. So I think besides the safety and efficacy of bioidentical hormones, one of my big problems with bioidentical hormones is that they're often promoted to women as kind of this fountain of youth, which they aren't, and nor should they be. Aging is a natural part of our lives. It's a natural process. But the way society makes us feel about our aging bodies often leads women looking for ways to either maintain or get back the way it was. Jennifer Gunter is a notable OBGYN out of San Francisco, and she notes that we all fear getting older, loss of sexuality, and the way society makes women feel, women are more vulnerable to it. Bioidentical hormones is a multi-million-dollar enterprise that takes advantage of that vulnerability. I think in a culture that really values fertile and young people, aging can make us feel unattractive and worthless. We beat ourselves up over our changing faces and our unrecognizable bodies. Instead, I feel like we should be embracing those changes, especially during times of transition, whether it's adolescence, motherhood, or menopause. We should embrace our changing bodies and cherish them. We should empower people to know that they're beautiful in all of their forms, even if it's not what society tells us to look like, or if we don't feel the way they tell us that we should feel. Nora Ephron, who is a fantastic writer, and I love her book on this topic, I Feel Bad About My Neck, and Other Thoughts on Being a Woman. She tells us anything you think is wrong with your body at 35, you will be nostalgic for at 45. But she also asks us to be the heroine of our lives and not the victim. We are going to be postmenopausal. We spend about a third of our lives in the postmenopausal period. And I think that we need to accept that and embrace it and make steps to make positive change so that we can make the best of it. Things like eating healthy and exercising can make us feel better about our bodies. Shifting into a positive thinking mode is hard, but it's really important. Sometimes therapy can help. But people who have a positive outlook on life radiate energy and are often perceived as being more beautiful. We should try to develop new interests, pick up old hobbies, rekindle relationships, and maintain them. Surround yourself with women who are going through the same thing, who are around your same age, who get it. By fostering this community and support and embracing each other, we can help to change the status and the kind of image of that. We can create change that makes you feel good about yourself and support and encourage others, like your spouse, to do the same. Often men around the same time are going through their own set of changes, and they may also be reluctant to talk about it. Society is not much more kind to aging men than it is to aging women, so I think it's important to keep that in mind. There are some great resources that I really like. The North American Menopause Society, or NAMS, they have the great website. It's very easy to remember. It's menopause.org. It's easy to navigate. They have information for patients and frequently asked questions, as well as the Meno notes, of which I provided some of those out at the back table on common symptoms and some of the treatments that we talked about. It has really good evidence-based information. And if you're looking for a little bit more in-depth, they have a book called The Menopause Handbook, which you can purchase through their website. There's also a new app that I haven't quite checked out yet, but I've heard good things. It's called the Rosy Wellness app, and it's free. You can download it on your phone. And the goal of it is to provide evidence-based information and resources for women who have questions about their sexual wellness. There's also the American College of OBGYN. They have some good patient information handouts as well. And then also you can come talk to your doctor. We love to talk about this stuff, and they're hard conversations to have, but it's definitely something important and to not feel alone. These are the references for my talk. Oh, and I didn't have the picture of my kids, but I would be more than happy to answer any questions.